as far as palliative care and all this pure thing is concerned. But then they are disparate. It's not the same in all the country. There are still adequate rehabilitation services and workforce shortages, financial barriers. Some can't even pay for physiotherapy or rehabilitation or whatever. Cultural beliefs and stigma surrounding pain and opioid use, poor integration of rehabilitation into oncology care. So that is how it is. There is this disparity, and when we have it in mind, that will give us the boost to continue to push for more physiotherapists to get interested in this aspect of care to help these patients, because this thing is much. Please, sorry, let me bring my. Oh, sorry, my internet. I need to put it my power bank, take my lights on so that I will not lose network. So I'm sorry. So why physiotherapy matters globally in pain stuff? So regardless of resources, certain physiotherapy offers several advantages. It's cost effective. It is safe. It's non-pharmacological. It can be adapted to different healthcare settings. For instance, opioid is opioid. There's no how you adapt opioid. It must be opioid. Even if I'm importing it or manufacturing it, it must be opioid. But physiotherapy, for instance, we may say that you want to do strengthening exercise. If you don't have weight, you can use TheraBand. You can use body weight. You can just adapt anything, in the community. That's what we mean. It's adapted to different healthcare settings, depending on the resources available. Then we will reduce disability, improve mobility, enhancing physical function, promote self-management, complement pharmacological therapy. But all these things we listed, they have application in pain management in cancer, because pain gives rise to most, or if not all these things. So now let's now go down to the business of the day. So what are the sources of cancer pain? Sources of cancer pain can be as a result of the disease itself, can be as a result of the treatment. It can be pain unrelated to cancer, but it's happening or occurring in a cancer patient, like the time I gave a sample when we're starting about new osteoarthritis pain in a cancer patient, but it's not a result of the cancer. That's why it's a comorbidity. So tumor-related pain is caused directly by the cancer. When it invades tissue and causes bone destruction, nerve compression, organ obstruction, inflammatory processes, all these things lead to pain. Maybe when we have cancer that has attacked the bone, can lead to pain, or chest wall invasion, or they have cancer that has compressed on the nerve and irritated it, and all those pressure leads to pain, or the inflammatory issues, as a result of cancer, inflammatory responses that happen. We also saw it and talked about it when we discussed our fatigue. So those inflammatory processes that lead to pain. So that's as a result of cancer itself. Can compress the nerve, compress the spinal cord. Maybe when it has attacked the spinal bone and there's collapse of those bones, spinal bone, all these things can lead to pain as a result of the cancer itself. So maybe when you're not doing treatment, surgery can cause muscular pain, or there is assault on the nerve during surgery. It can now lead to the neuropathic pain much after the surgery is gone and healed itself. Then you can have chemotherapy-induced peripheral neuropathy, which also leads to pain and other sensation, and also leads to some issues with balance in cancer patients. It's also happened in HIV, but not as a result of chemotherapy, but HIV drugs, antiretroviral therapy. It also gives rise to HIV induced neuropathy, peripheral neuropathy. But this one is as a result of chemotherapy. Then radiation fibrosis, fibrotic issues, the skin and muscles become fibrotic and forms hardened, cord-like, and adhesion setting, leading to pain, post-mastectomy pain syndrome. So these are common and very, very common in cancer survivors. That's pain as a result of the treatment itself. The treatment is supposed to cure, but it's now how some pain side effects. You can see that radiation has it, surgery has it, chemotherapy has it, Anything that we didn't mention here is all this hormone therapy and immunotherapy. But you can see the major treatment, they have side effects. Then we'll have pain that is unrelated to cancer, but it's occurring from cancer patients, occurring in cancer patients, but maybe from other medical issues like osteoarthritis, mechanical low back pain, because somebody that has cancer can also have mechanical low back pain. Diabetic neuropathy as a result of diabetes occurring. Just comorbidities. There are some comorbidities that will come with pain, not because of the cancer, but it's just that it's happening in a cancer patient. Then let's classify pain. We have different classifications of pain. One of them is according to pain mechanism. The mechanism of the pain can lead to what you for the pain. So first one is when we're talking about mechanism, is nociceptive pain. Nociceptive pain from nociceptor. That's pain, peripheral nociceptors, peripheral nerve endings. From damaged tissues, they pick up, noxious stimuli. So it's called nociceptive pain. So it's divided into somatic and visceral. So in somatic, we know this, but we must have to touch it because we are talking about pain. We build from known to the unknown. Somatic pain originates from the bone, muscle, skin, connective tissue, and joints. I just decided to list them so that even when you read it, you can understand it. It's not so simplified anyway. Then visceral pain originates from internal organs called viscerals. That's just like liver, pancreas, bowel, that's intestine, and lungs, whatever. But then what differentiates two of them, whether it's somatic pain or whether it's visceral pain, is as a result of the characteristics. In the somatic pain, which originates from bone, muscle, that's musculoskeletal tissue, muscle, skin, bone, connective tissue like tendon, ligaments, and joints. All these 5 of them. It is localized. When you point, you palpate that point, the person will feel that pain. Yes, the pain is here. It's well localized and it's sharp, very sharp, and aching or throbbing. So these are, like aching. You have a headache, them, throbbing like it's breathing there. So, but when you come to visceral pain, it's fully localized. If you know the position of the stomach, you go there to palpate it. You will find out that what you are palpating, you are not feeling the pain then, but you are palpating it, but you are not feeling the pain. So, and it's deep. Your touch cannot elicit that pain. It's cramping and it's pressure-like. So it's most often time referred to distant places. For instance, stomach pain is referred, that's ulcer pain from the stomach, represented to the upper back, even to the shoulders. Yes. So that is how you differentiate. If it is somatic pain, it can be localized as sharp, aching, or throbbing. So especially when your localization is one of the, easiest way to differentiate them, even if you cannot find your way around other characteristics. But that localization is very, very prominent and important. So when you know the mechanism, it can help you in assessment because you have to group and know the mechanism. It can affect and influence the treatments you are going to give to those patients. So the second one, apart from the nociceptive pain, is neuropathic pain. This one is still under the mechanism. The first one is nociceptive pain. The other one is neuropathic. So mechanism is when it's coming from organs and tissue. So neuropathic, of course, when it's also somatic or when it's also somatic or visceral. Of course, that it's still the free nerve endings that carry those noxious stimuli and stimulate them. So it still passes through the nerve. But then in neuropathic, it is now caused by lesion or disease affecting the nerve itself. In visceral and somatic, which falls under nociceptive pain, the nerve that transmits the pain is not injured, does not have any issue. But in neuropathic, it is the nerve, a lesion or disease or any mechanical obstruction or compression affecting the nerve that triggers the pain. The tissues are okay, but the nerve is what is affected. So maybe there's nerve infiltration of tumor or even tumor of the nerve. You have tumor of the neuroma For instance, neuroma is tumor, so all those things. So nerve compression, maybe when the tumor is expanding and invades and compresses nerve, then there is all this chemotherapy-induced neurotoxicity that goes to attack and damage nerve. Yes, we have chemotherapy-induced neurotoxicity. So these are part of the things we'll be looking at. So management of, side effect of chemotherapy. Physiotherapy, yes, it leads to pain as well as chemotherapy-induced neuropathy. These are side effects of treatment. Radiation-induced nerve injury, even the radiotherapy that they do, some of them will have effects, assaults on the nerve. Then they also have surgical nerve damage. So these things are what may affect the nerve and injure or have some chances of causing neuropathic pain. So what you see there, of course, we know that the other ones are localized, non-localized, throbbing, aching. The other one is deep, dull, But this one is burning pain, like electric shock-like sensation, to show you that it's from the nerve. It can have tingling, especially when you have neuropathies, numbness, especially when you have neuropathies. That's when, hyperalgesia and annoying nerve. When things that are not supposed to cause pain will cause pain, because the pain threshold is highly reduced. So anything that's not supposed to cause pain will just pop up because it's not hypersensitive and even to hyperalgesia. So, of course, example is neuropathy, chemotherapy-induced brachial plexopathy, phantom limb pain. But for this cause in oncology, is chemotherapy-induced peripheral neuropathy and brachial plexopathy. That we are taking as examples. So, neuropathic pain often responds effectively to opioids. You see how determining the mechanism is very, very important. Because if that pain is from neuropathic origin, rest assured that opioid treatments, which is the top of the WHO ladder in pharmacological intervention, will not effectively take care of that. So the other pain management modalities must come in, which are non-conventional, or if you like, you refer to it as adjunct, including physiotherapy. So if you have determined the mechanism in neuropathic, you just stand by because eventually opioid, will not take your feet. So another one is mixed pain, is still on that mechanism related. So sometimes this pain may not be either nonsensitive or neuropathic. You can have a mixture of nonsensitive and neuropathic. So you must have to know, of course, when it is mixed, so that it can affect your intervention. So, for example, a patient with metastatic breast cancer involving the humerus may present with breast cancer, but the thing has metastasized and also affected the humerus. Of course, bone destruction can give you somatic nonsensitive pain. Of course, bone affectation leading to pain is under somatic. It can be neuropathic due to brachial plexus compression as a result of this affectation to the humerus and pain. So muscle pain resulting from protective guarding and reduced movement. So a mixture of these things can be common in oncology. That's why assessment is very, very important. That's why we're even talking about this classification, because we must have to assess, we must pin down. You don't just give visual learning scale, pain rating scale, and say 7/10, 8/10, it's 9/10. That is pain is too much. No, we must have to determine the type of pain and the cause. So now, central sensitization. Persistent nonsensitive input may induce neuroplastic changes within the central nervous system, leading to central sensitization. So when there is consistent and persistent noxious stimuli coming to the brain sometimes become hyper excitable. That's hyper excitability in pain perception and interpretation. That is that's how best I can describe this central sensitization. You sensitize it and it picks up pain and amplifies it. So it's central sensitization. So even if it's nonsensitive pain, neuropathic pain, but the thing is that it is persistent. At a time, it is amplified because there's another momentum given to it called central sensitization. So we have to also know the characteristics of cerebral sentinel so that you know when it has happened. So pain is proportional to tissue injury. This may be just little thing, but then the the pain will be too much compared to its widespread hyperalgesia and enhanced pain response. Sometimes it may not be easy to just fish it out, but at the level of the pain you're having, it may be the same character because now hyperalgesia and anodynia is obtainable in neuropathic pain. But when you have hyperalgesia and anodynia and you know that it's neuropathic pain, at the time that hyperalgesia and anodynia increases in intensity, you understand? You may be pointing that central sensitization, has come in. So when there's new nociceptive inputs, then there are these neuroplastic changes in the central nervous system. It amplifies pain signals and then hypersensitivity. So we just have to know these things. Sometimes it may not be easy for you to pick it, but when you constantly practice in oncology setting, you become familiar with these things and it becomes easier. So now we have finished classification according to mechanism. We are now looking at classification according to duration. Because we know this one is very easy. Acute and chronic pain. Certain onsets for acute and it's usually associated with tissue injury or inflammation. But for the chronic, it is not sudden. It's something that comes gradual and it persists and reoccurs continuously more than 3 months and beyond. So I wouldn't want my time in this one. We know this one well. So only that you can just look at the example, post-operative pain, acute pathological fracture, mucositis, drug chemotherapy, and acute radiation reactions. That's the acute pain. Not limited to that anyway. Then chronic cancer pain may result from persistent small growth, of course, gradually, but ongoing inflammation, which is a continuous process. Fibrosis, maybe because of radiotherapy. Then neuropathy, central, all those things. So there is nothing. But what we have to know, that acute one may not have issue, but when it enters to chronic, that is because of its effects, clinical significance. That is what matters, and we're giving attention to it. Ordinarily, we wouldn't have, because acute is protective in nature. Acute pain, just like let's leave cancer pain. Maybe somebody pinches you with a needle. This withdrawal reflex is protective. So acute is usually to tell you there's a danger so that the body will now react. So is that reaction, whatever goes on, that determine whether it will extend to chronic or not. But if it goes to chronic, it will not have impact on the body system. Like physical function will be affected, mood, sleep, participation in daily activities. So that is why we will give it attention. That's according to duration. So our classification according to temporal pattern. I think we discussed this a bit in fatigue. Continuous pain present most of the time with relatively stable intensity. We call it baseline cancer pain. Even when the cancer pain is controlled with drug, there is baseline cancer pain that exists. So even at rest, it has stable intensity. It doesn't alter. It's just there that is there. It's continuous pain, baseline cancer pain. But we have this breakthrough pain, which we have discussed, mentioned it when we're discussing fatigue. So when somebody is having opioid, but even without opioid, there is normal pain that exists as a result of the fatigue and first. Suddenly, you have taken your dose of opioid, which you last for just 4 hours, and within 1 hour or two, you now have a spike of pain. Of the worst instance that you felt when they introduced, opioids, like when we are not taking opioid before they introduced opioid. And it spikes, but the only thing is that it stays from seconds to not more than 1 minute. It stays from seconds, it doesn't stay up to 1 minute. It now goes down. Sometimes it can be incidental because some movement can also now trigger it. So if incident pain is part of breakthrough pain in cancer patients. So if it is an incident pain, there are sometimes you can know that there are some incidences that may trigger it. Maybe when the person moves to go to the toilet, coughs. When the person coughs, so it becomes anticipatory. So that this thing we call anticipatory analgesia. But when the person wants to engage in that activity or carry that movement, the person can take some analgesic medications before that time because it's intention. But this breakthrough pain, you cannot actually determine. It's idiopathic. It is only the only thing that they've associated it with is end of dose failure. They are giving opioid of a particular dose. They now say that that dose has failed. So pharmacologically, it is beyond the scope of this course. We have calculation, even we have calculation, so that we know, but we don't calculate what we don't give. But because you practice in cancer and palliative care, so you have to, then you have to recalculate the dosage that you add to that one. But you can only do that addition only when there is breakthrough pain, when it has occurred. So when you recalculate, because it's associated with end of dose, so that's the only expression that can be given to it. But as for the cause of it, you see the particle nobody knows till today. So when you recalculate, so now add to that dose of the initial dose of the drug or whatever morphine like this person, and it's spontaneous, yes, and that's why we end the dose failure. So what is the significance of this breakthrough pain in physiotherapy? That's why we are mentioning this thing soon. Physiotherapy sessions should be timed with optimal analgesia, and intervention should be modified to minimize predictable pain exacerbation. For instance, if it is incidental, there are some of them that the incidence that triggers it is physiotherapy session or physiotherapy treatment. That after physiotherapy, the pain gets worse. In cancer patients, incidence pain in cancer. So you now have to know, the intensity of what you are giving, what modification you are doing, so that you can cut the pain and incident, of course you can now go around so that it will not exacerbate or trigger it. And also, you don't have to time the the optimal analgesia period. Half-life. Every drug has half-life. So that's why collaborative teamwork is very, very important, because we have to communicate with the physicians a lot, even with the nurses. Because sometimes when they give these drugs and when you come, as well as maybe you have so many patients, you may not really tell you. So when you work this timetable out with nurses, so that it will be favorable to each of you, so that when you're coming or when you administer the drug, we coincide with when you're coming, and that time we coincide with optimal the peak period of action of the drug, so that you'll carry your treatments and move on. So that is why it's very, very important for physiotherapists to know all this is. But this is when there is breakthrough pain or it's occurring in a patient before you take these actions. So why do we even identify the mechanism of pain? It's important, because it can enable us as physiotherapy to select appropriate interventions. For instance, we have talked about somatic, visceral, neuropathic, mixed, and central sensitization, and their clinical features. We are not going to read into them. What is physiotherapy consideration? What is happening? If it is somatic, it now tells you which kind of physiotherapy intervention that you can give. You can see that exercise, manual therapy, position, and mobility restoration, thanks for analgesia, comes in. Understand? Then interferential therapy for deep musculoskeletal pain or muscle spasm. You understand? But you must not be given over at this side. So when you take time on your own, because I have to release this slide to now see it, it's not what you be mentioning here. Even if I mention it, there's no further explanation to it. If it's visceral pain, nostalgic pain, you see gem position, breathing techniques, tense, like neuropathic pain, tense can play a role. Then you see photobiomodulation. There's a new technique that they call photobiomodulation. I will deal with the organizers of this bootcamp, but at the end of everything, I want to take a topic in photobiomodulation. Yes, maybe the research in it, one of our colleagues in international IPTO. So she presented to us. It was a full 2 hours presentation on photobiomodulation and what they're doing. It's not here, but they did it there and it's working real pretty. So I would like to share that knowledge with everyone until we get there. And if it's missed pain, what we can do, central sensitization and all of that. So what is the pathophysiology is just to run through that. because these things are what things that we would have given good time. But we also, part of it is what we have discussed in fatigue. Because, of course, tumor, cancer leads to inflammation. Of course, we discuss it a bit deeper in fatigue. It's still the same thing. When you see that slide, you understand this. But just that there's a little variation. Of course, when the tumor is growing, its effects and the effects of cancer treatment on the tissue, on the bone, on the nerve, that is what leads to inflammation. Not only in fatigue. We talked about only effect of the inflammatory process response as a result of the cancer, and how it can lead to fatigue and all this, the muscle weakness and all of that. But then the cancer can affect the tissue. In addition, the treatment of the cancer can affect the tissue. So not only the cancer, but its treatment affecting the tissue. Leading these two things, amplify each other to give an amplified inflammatory response and cell damage that occur in the tissue. They also bone destruction as a result of the cancer. The treatment does not destroy the bone, but the cancer can affect the bone. So because the tumor can have invasion of the bone, then you have osteolysis, and it weakens the bone structure. The bone becomes fragile, and the mineral density is also reduced. They can also affect the nerve, both the cancer and the treatment. Direct compression or infiltration damages peripheral nerves. All these things, these three things, this effect on the nerve, bone, and tissue, gives, rise to inflammation. Before you know it, the inflammation becomes systemic in the body. And these inflammatory substances that are released, tissue necrotic factor, interleukin 1 beta, interleukin 6, and all those things, necrotic growth factor. So you now see that they reduce the nociceptive threshold, pain threshold of the nociceptors. They reduce the pain threshold of the nociceptors. So now find out that stimuli that are actually not supposed to be noxious becomes noxious, that is anodilia. And the nerves become hypersensitive because their pain threshold has been reduced. So that is peripheral sensitization now sets in because these nociceptors become hypersensitive and hyperexcitable as a result of this inflammatory issue. So that's this when it becomes persistent, that's an inflammatory thing gives rise to peripheral sensitization. Remember, peripheral sensitization is different from central sensitization that we said. So central sensitization is a result of continuous input from the peripheral nociceptors to the central, to the brain. But then those peripheral nociceptors can actually be sensitized, their own sensitization, as a result of these inflammatory responses from tumor and the cancer treatments. And this inflammatory response release metabolites that are noxious, and the pressure of inflammation and swelling also compresses on this thing. And what it does that it reduces the pain threshold of the nerves. And once it's reduced, stimuli that are not supposed to be noxious or that their test has not reached the magnitude to cause pain. That is anodilia. It can now blow somebody. Just that to bleed somebody. Person feels pain, yes, anodilia. And you have hyperadjacent, by exacerbability. So when this happens, so the peripheral nerve are sensitized and they keep firing, at a higher level, giving, pain signals that amplify. And its persistence will now also lead to central sensitization, So the spinal cord and brain becomes hyper-excitable on their own, the way the peripheral nerves becomes excitable, leading to pain amplification and hypersensitivity in the central system, in both the spinal cord and the brain. So its final effect is that pain is amplified and interpreted. And those pain can lead to weakness, muscle garden, reduced activity. And when there's reduced activity, lack of mobility because of reduced mobility because of the pain, and anesophobia, fear of fall, and all that, and all those psychological issues. It can only amplify the muscle weakness that's in the muscle. It leads to fatigue and disability. All those activities, distraction and participation, all those things we discuss in fatigue. So multiple systems interact with physical activity is reduced, and the conditioning and the cycle, continues again. If you look at the boxes on the right, you can now see other things that are put there. You get this. So this is just to summarize it. So it's just in a summary. So biological targets of physiotherapy. What do physiotherapy target? First, we have the cancer pain mechanism. Inflammation. Yes, we target inflammation. Yes, your physiotherapy targets inflammation. So peripheral sensitization, those anodular hyperageusia as a result of the inflammatory effect that reduce the pain threshold of the peripheral nerves. Central sensitization. So therapy targets is what you do to tackle pain. Muscle weakness. These things are now the effect of the pain. You must tackle muscle weakness if you feel the pain, you do not tackle the muscle weakness. You have not done much. The conditioning, fibrosis, and reduced mobility. These are what gives you the impact to have as a physiotherapy in this area of practice. Then physiotherapy. What are the physiotherapy that you give? Exercise, manual therapy, electrotherapy. You give education, breathing exercise, functional training. These are what you use to take care of cancer-related pain. And these things you do will have effects on inflammation, pain, strength. These are measurable things as far as ICF is concerned. Inflammation, pain, strength, mobility, yes, function, and quality of life. So you target the underlying biological mechanism to improve function on those things. So you can see that those mechanisms that lead to pain, when we come to treatment, we see that physiotherapy affects each one of them. And when it affects all those things, you are shutting out. You understand that's a pain process as much as you can. That is what you are bringing to board. So the clinical implication of this mechanism. So understanding pain pathophysiology allows physiotherapists to select intervention based on dominant pain mechanism rather than pain intensity. Like I've said, it's not enough to come and use visual analog scale of 1 to 100. The person says 70 over 100, that kind of thing, or whatever, or pain rating skills. Beyond that normal recording of the intensity using numbers or ruler, you have to, from the characteristics of the pain, you have to characterize the pain. When you characterize the pain, you will now know which one, because they can be mixed and sometimes it can be confusing, but you will be able to find out the dominant pain mechanism, and that is what you will focus. If you can tackle the dominant pain mechanism, you would have achieved significantly some level of results. You can, when you know it also helps you, number 2, to modify exercise prescription according to tissue pathology and medical stability. It can help you to know when the pain is inflammatory, neuropathic, nociceptive, or is mixed. Then you can collaborate effectively, and you can be able to educate the patient. There's nothing bad in educating the person. Whatever the person is passing through, the person wants to know more, because I have to understand if the person wants to know more. If the person that wants to know more, you have to tell the person all about the pain, because that is one of the things involved in pain education. The person must have to understand it, before you start putting up a positive coping mechanism and the acceptance of the treatment. So it's not one single mechanism. So sometimes there's overlapping mechanisms, because most of these things happen in the same patients most of the time. But we should be able to discover the dominant mechanism and be able to find out others, even if we cannot. When we tackle the dominant mechanism, if it is out of it, the ceiling has been removed for other ones that are under also manifest. We cannot beat them up. So let us look at that ICF framework. I mentioned it, but it's very, very important. Always use this. It's what gives you the impact that you have as a physiotherapist, even when you're making case for policy change. ICF framework applied to cancer detect pain. Of course, ICF International Category of Function is Safety and Health and ways. So body functions, the pain is to weakness, it's associated with fatigue, disuse and gagging because of the pain, and if inflammation is not restored, can lead to stiffness, dislocations with statin, neuropathy, needs pain because of surgery, because of chemotherapy, and this how it affects the body parts and structures. It affects the body functions and structures. So once that happens, the cancer-related pain also it's now when it's affecting the body functions. What next thing that you see is that the activity, daily tasks is also affected in working, in dressing, in bathing, in transfer, in clothing step. The degree differs, but I have seen it in oncology clinic. Even to dress, to eat, to bath. These are serious issues, not because we have experienced people at different stages that lead to participation restriction in employment because of absenteeism. Some of them lose their job. And research has shown that it takes cancer patients, double, this thing, possibility of getting work in re-employed again in a cancer patient that has lost their job is 100% more, is double of a normal person that just maybe that terminated appointment and lost lose your job. So absenteeism for employment, or even when the person is self-employed, we once have a petty trader, a woman that sells food. He uses her hand to, who's beans and ties and all those stuff, and it's right-handed dominant. So now, cancer with cancer, lymphedema of the upper limb cannot raise the hand, stage 3 lymphedema, pain, weakness, cannot even hold a grip, form a fist of his hand. So, she no more goes to markets because she cannot start putting food at time. Say, do you have any more that it's known that the shop is closed now? She's losing money. And the cost of the cancer treatment is enormous, not talk of also physiotherapy, including the chemotherapy. So, family rules, such a person cannot fulfill family rules, house chores and role in family. Not talk alone. Actually we asked of this in breast cancer patients. It affects their sexual function. Some say that for over 1 year now, they are no more doing having sexual intercourse with the husband. And some say that because of the cancer, the husbands, because of mates associated with cancer, the husbands do not also give in to having sex with them. And it increases promiscuity because this causes breakdown in family communication. So our participation in social activity, is also reduced, recreation, reduced, and community life. And this thing affect the quality of life because once someone cannot engage in normal activity and gets involved in participation in the roles they used to play, the quality of life is too more to write up about. But these things are compounded also by environmental factors and personal factors, the quality of life, because motivation level, coping strategy, and resilience of the patient and belief of the patient also matter. That's why psychotherapy is very important. There are some people that are highly motivated. Because even if they are going down, they believe that they cannot go down. So you cannot I compare the personal quality of life with somebody that is moody, crying always, has no coping clarity, believe that it's already dying. So when apart from the body function and all those things, depression, there's a lot of pain, personal factors and environmental factors also compound its negative effect on the quality of life. So the take home here is that a reduction in pain intensity is important. You understand? Maybe we just came your measure and say the pain is 9/10. You reduce it to 5 or 4, no problem. A reduction in pain intensity is important, but it does not necessarily indicate successful rehabilitation. A patient whose pain remains moderate yet returns to work, resumes family responsibility, and regains independence has achieved meaningful rehabilitation outcome than somebody that's the pain is now mild, but you're unable to tackle the muscle function weakness that has set in. You understand? You are unable to restore the cardiopulmonary endurance. You are unable to return the person to the normal work and all those things, So that's what is actually the point is making. That functional improvement and participation should therefore be considered equally important indicator of success in oncology physiotherapy and in pain management, because pain has a role to play in the affection of body structures and function that may lead to activity, limited activity, and participation restriction. So let's go to assessment because I know we'll be waiting for this one. But it's all of these are just also a summary. So physiotherapy assessment of cancer-related pain. we have part 1, 2, and 3. So part 1 is clinical reasoning, subjective assessment, and mechanism-based pain assessment. Because in assessing cancer pain as a physiotherapist, you have to apply a high degree of clinical reasoning, in your subjective assessments, and you have to identify whether the mechanism of the pain, you have to classify that pain most based on the mechanism. So clinical reasoning framework assessment should follow a structured clinical reasoning process. So when you want to do assessment, you have to follow this part. Patient interview first. We are talking about subjective stuff. Patient interview. After you interview the patients, you are not assessment. You now do red flag screening. We will tell you why. Not in this slide, when we get there. Identify pain mechanism. If there is no red flag, you can continue. Now assess to identify the mechanism. Through asking of questions, because we have characterized the pain. What is the characteristics of the pain? So from the characteristics, you can know the mechanism. After that, we'll now go to physical examination, because they have done red flag. If there's red flag, you cannot continue. Or if there's no red flag, you will come to that physical examination. After you have done physical examination to identify where the pain is and all those, and you now do functional assessment, because that pain must have interfered with function. That is why it is very important, pain and fatigue. Not only that they have it, but it also interferes with function. So after you have done your functional assessment, you can now be able to set your rehabilitation goal, which will cover both the mechanism of the pain in order to reduce the pain and the functional impact the pain has had, as a result of the effect on the body's functions and structures. You now set your rehabilitation goals to cover this functional aspect and the mechanism, aspects of the pain. You now develop individual pain treatment. So in patient interview, we take it one after the other. We listen to just small point. You take the history, the onset of the pain. You take the duration, because you have to know whether it's acute or chronic. How it's set. Was it gradual or was it sudden? Location of the pain matters. Then character. That is when you are characterizing it. When you characterize the pain, it should be leading to, telling you the mechanism. The intensity. Now use the bars, but we have characterized this first. So try to pin it down to